Welcome back to the channel. So today we'll go through a neurology shelf review, the last of the initial shelf review series. So we'll start off as usual with some practice questions, go through answers, and then explain the concept behind each answer. We'll then do some differential diagnoses. That's kind of the best way to approach the differential when it comes to practice questions on NBME exams. Kind of what keywords are they looking for to differentiate each disorder, and then we'll do a rapid review so that you can review this quickly before your shelf as well. So let's go ahead and get started. So first question, a 67-year-old male presents to the emergency department 2 hours after developing right-sided weakness while eating dinner. He reports dropping a spoon and suddenly feeling weak. Vitals include a pulse of 80, blood pressure of 180 over 90, respirations of 16. Physical exam shows strength of 2 out of 5 in the right upper and lower extremities and 5 out of 5 in the left upper and lower extremities. Non-contrast head CT demonstrates no significant findings. So which of the following is the best next step in management? We have choice A, intravenous nicardipine, B, tissue plasminogen activator, C, oral nifedipine, D, warfarin, or E, surgery. So I'll give you a second. Okay, so we'll click to the answer here. The answer for this one is TPA. So we'll get to the explanation for this, but TPA was the choice here in this situation. These are classic symptoms of ischemic stroke. The head CT demonstrated no bleeding, and so you know that you're within the window. The 2 hours is within the 3 to 4.5 hour window, so you know TPA is what you do in this situation. So let's go on to the next one, which is the second part to the same question. So same question here, same situation, same person, and we have bolded here the change. So repeat contrast, non-contrast CT of the head reveals a new focus of hyperdensity in the basal ganglia. So it gives you a series of slightly updated vitals, and now you have this hyperdensity in the basal ganglia. So which of the following is the best next step in management for this patient now? We have the same choices here. A, intravenous nicardipine, B, TPA, C, oral nifedipine, D, warfarin, or E, surgery. Once again, I'll give you a second here to go through this. Okay, so the answer for this one this time is A, intravenous nicardipine. So in this situation, the cause should stand out. So a person with ischemic stroke given TPA now develops worsening symptoms, headache, nausea, vomiting, and elevated blood pressure, and now this hyperdensity in the basal ganglia. So what this tells you is they've had a hemorrhagic transformation. And so now, while we're here, let's go to the explanation for both of these. So this question was really meant to get at ischemic stroke versus intracerebral hemorrhage. This is a common topic tested on NBME exams, and they often just want you to differentiate the two and what the goals are between the two in management. So we'll start with ischemic on the left side. So ischemic stroke, acute ischemic stroke, you have different blood pressure goals depending on if TPA is given and based on your window as well. So if given TPA, prior to TPA, you choose a goal of 185 over 110. You want the blood pressure under that. Under that, you're okay. You don't need to give any other extensive hypertensive emergency medications. And then 185 over 105 after the TPA is given. But let's say you don't give TPA. Let's say the last guy in the situation came after 5 hours, for example, and you couldn't give TPA anymore. So if you can't give TPA, you maintain the blood pressure at higher levels, so 220 over 120, and this is also known as permissive hypertension. So remember that the goal for blood pressure is different if given TPA versus not. The threshold on NBME exams you want to use is less than 4.5 hours. There's another important threshold that if you're less than 24 hours and you have VAN symptoms. So V stands for visual symptoms, so that would be the hemianopsia. A stands for aphasia, and then the N stands for neglect. And what these tell you that these are the only time these are damaged, so aphasia and neglect are damaged in large cortical strokes. These happen in large vessel occlusions. So that tells you whether or not you can do a mechanical thrombectomy. Before you do a mechanical thrombectomy, you need to get a CT angiography of the head and neck. This is a vessel study. It's going to show you the occlusion. And if there's a large vessel occlusion, you can do a mechanical thrombectomy. So remember, you can do one TPA thrombectomy, or you can do both of these. These are not mutually exclusive. They're separate, and they don't depend on each other. They have different thresholds and timings. So let's move on to intracerebral hemorrhage. So the blood pressure goal is 140 over 160. So a much lower goal. In an ischemic stroke, the blood can't get through a clot, and so you let the blood pressure stay higher. With intracerebral hemorrhage, there's blood leaking out of the vessels in the brain, so you want to keep the blood pressure lower to prevent further leakage. So it's the exact opposite concept. So you also reverse anticoagulation, which makes sense. So if given TPA, you can give aminocaproic acid, for example. You want to make sure that you reduce any other likelihood causes of them bleeding. If they're on warfarin, you could potentially give FFP and vitamin K, so on and so forth. You also maintain normal ICP. Remember, as you leak blood into the confined intracerebral space, you can develop increased ICP. So you want to elevate the head of the bed. You can hyperventilate the patients. You can give mannitol. And indications for surgery. So impending herniation, if they look like clinically or on imaging that they're beginning to herniate, or if their symptoms, the signs of ICP, like the last question, elevated blood pressure, nausea, vomiting, headache, papilledema, so on and so forth. Those are indications for surgery. So it may seem stressful in a test question to not pick surgery in these patients, but actually medical management is typically preferred on the exams. So these are the main things we wanted to test. So the first question was testing if you realized that it was an ischemic stroke within the window, so you give TPA. And then the second question was a hemorrhagic transformation, which you treat a little differently. You treat with a much more strict blood pressure goal. Let's move on to the next one. A 17-year-old male presents after a head injury during a soccer game. His head collided with another player's knee, and his teammates reported that he appeared unsteady shortly afterwards. Denied loss of consciousness, but endorsed nausea that has since resolved. Vitals are there. Full neurologic exam demonstrates no significant findings. Non-contrast CT of the head reveals no acute abnormalities. Which of the following is the best next step in management of this patient? A, complete bed rest for 1 week. B, intensive care unit admission. C, serial head CTs. D, 1 to 2 days of rest. Or E, immediate return to activity. Okay, so for this one, the answer is 1 to 2 days of rest. So this is a classic presentation of a patient with a concussion, a young player, no past medical history, in a sporting event, develops mild to moderate symptoms that either resolve or seem mild in comparison to the injury. And so the first step is 1 to 2 days of rest. Let's move on to the next part. So after a 24-hour rest period, this patient now returns to light aerobic activity, progressed to non-contact soccer practice, while participating in practice now redevelops headache and nausea. After an additional rest period, which of the following is the best recommendation for this patient? A, light aerobic activity. B, referral to neurology. C, serial head CTs. D, advise discontinuing sports indefinitely. Or E, immediate return to activity. The answer to the second part of this question is light aerobic activity. And both of these have a very specific and very high yield reason why we talk about it here. So let's go to the explanation now. So this is all to test the concept of concussion. So concussions are mild traumatic brain injuries that occur with usually high velocity force, oftentimes in sports, and especially in young patients. So the first step, always the first step is remove them from their same day activity if they develop symptoms. So this patient had nausea, maybe had some vomiting, felt unsteady. If they lost consciousness, you remove them from activity. You don't want that to happen again in the same setting. The next step is you do a full neurologic evaluation, and you can get a head CT. Usually they'll just give you the results in the test. You won't necessarily need to get one, so it's not usually the question they're going after. The next thing that they do go after a lot is rest for 24 to 48 hours. Depending on the study, you'll see 1 day, other studies may say 2. So usually 1 to 2 days is okay. Then once you've done the rest period, assuming there's no focal neurologic deficits, no signs of herniation, just a simple concussion, the next step is gradually return them to activity. So you have to progress through stages. So you start with light aerobic, which this patient did. You then progress to non-contact and then to full contact again. And so here's the final trick that they like to test recently since people have learned these first 4 steps. So if symptoms redevelop, like this patient who redeveloped some nausea, headache, similar symptoms to their original concussion, these are signs that the concussion or the symptoms are redeveloping. So what you need to do is go back to step 3, repeat 24-hour rest period. So you're trying to give the body a chance to recover from the injury. So if you develop the exact same symptoms, that means the body is not recovering. And then once they have repeated that, you start at the previous activity level. So this patient, for example, had progressed to non-contact and then developed symptoms. So what do? You send them back to light aerobic and say you're going to have to progress daily between these 3 stages. So you step back 1 step and then you move on. And if this keeps happening, you keep stepping them back 1 step until they're able to tolerate, and then you keep progressing forward. So don't forget, it's not just a one and done thing. They always recover. Sometimes they redevelop symptoms, and you just have to backtrack and start over. So those are the basics and the high yields for concussion. So let's move on to the next one here. We'll go ahead and get started with our differential diagnoses. So the first one is brain hemorrhage. So what are the different types of brain hemorrhage that come to mind that are highly tested on USMLE exams? I'll give you a second to think of some. Okay, we'll go on and click 4 here. We click forward to the high yield and ones that are usually tested and ones that are important to distinguish. These are always what we focus on these. So I have a picture here on the right and correlates with the color of each that I've listed here on the left. So the first one is epidural hematoma. So we'll split it into risk factors, presentation, and then any other high yield information. So the risk factor for an epidural is classically trauma. So if they ask you what the risk factor for this is, it's going to be trauma. The presentation on board exams is that they have a brief loss of consciousness, then they have what's called a lucid interval. So they're not going to tell you they had a lucid interval, but what they'll tell you is the person was conversing, they were able to explain what happened to them, they feel fine, and they insist that they have nothing going on. And then they rapidly deteriorate and progress to oftentimes comatose. So that's very high yield of a presentation to know. So remember the high yield for epidurals. So it's a biconvex appearing lens-shaped density. So if you see here, that's what this is. This is a biconvex. So it's convex on this side and it's convex on this side. So it's biconvex. And the reason for that is that it's stuck between the sutures here. So it can't progress between the sutures. So it extends, stretches the dura, and then it stops right when it meets the suture lines. So the pterion is not in this picture here, but it's a bone that's a common place where epidurals occur because the sutures all meet up at one portion between the conjunction of 4 bones. So it's a common place that the epidurals occur. And then an anatomic origin is the middle meningeal artery. So that's what ruptures and leaks into the epidural space. So that's also very high yield to know. They often test the anatomy of these more so than just knowing which type of hemorrhage it is. So then we have subdural. Risk factors are age, so the extremes of age, elderly patients, basically, and infants. So why do these patients have higher risk? Because when there's cerebral atrophy, so when the brain has lower volume relative to the space, so elderly patients, as the brain atrophies as we age, and then infants who are developing the size of their cerebral cortex. These patients have the cortex further away from the skull. The bridging veins have to stretch across a further distance, more likely to rupture. And then a similar reason for alcohol use. Alcohol can decrease cerebral volume with chronic use and be a risk factor. So this presentation is not as high yield, but they progressively get confused, can have a headache, and it can progress to focal neurologic deficits. Remember that instead of a biconvex shape density, we instead have a crescent, and that's because as it extends here below the dura, it escapes past the suture lines, and so it extends and basically is compressed against the cortex here. So it appears as a crescent on imaging. Hyperdense is acute, as blood that's pouring out at a fast rate on a CT scan is going to appear hyperdense, so bright white. If you see a hypodense appearing crescent-shaped lesion, you know that it's a chronic or subacute subdural. And so just know that oftentimes patients can have these stacked on top of each other. So you may see a chronic appearing crescent that's dark and then another hyperdense one on top of it. So these can stack on top of each other. And the anatomy here is the bridging veins. So the veins, they're not detailed very well in this picture here, but the bridging veins that stretch across underneath the dura can rupture when the cortex is atrophied. Moving on, we have subarachnoid hemorrhage now. So the classic risk factor are baryaneurysms. It's not the only risk factor, but this is the one they test on exams. So autosomal dominant polycystic kidney disease is a risk factor. It causes baryaneurysms. So the classic presentation is a thunderclap, severe, worst headache of my life. But the next thing that people don't think about oftentimes is there's nuchal rigidity. So if you see the most rapid onset meningitis you've ever heard of, it's probably a subarachnoid hemorrhage. High yield, so they'll say blood in the basal cisterns. It'll basically, if you look at an imaging and you see a hyperdense lesion that looks like the circle of Willis, it looks like somebody drew the circle of Willis, then that's what this is. For the workup, you do a CT followed by a lumbar puncture. So only lumbar puncture if CT is negative. And then remember, you need to use nimodipine, calcium channel blocker, to prevent vasospasm in these patients. And the last one here is intracerebral hemorrhage, which we touched on in the first practice question. So risk factor, this is actually pretty high yield. So you separate it based on location. The basal ganglia, thalamus, pons, and cerebellum, the risk factor is hypertension. These are small sort of subcortical structures that are perfused by lacunar and small vessel perforators. The cortical regions, the parietal and occipital lobes specifically, are supplied by large vessels, the MCA and PCA. So cerebral amyloid angiopathy is an amyloid complication that can lead to cortical bleeding. So keep these locations in mind if they ask you for risk factors. The presentation is classic for increased ICP, so rapidly progressive symptoms, focal neurologic deficit, so on and so forth. So if you see here with intracerebral hemorrhage and then a subarachnoid hemorrhage, you may ask on an exam, how do you differentiate these two? Well, usually it's going to be focal neurologic deficits. The intracerebral hemorrhage here is directly compressing cortical structures, right? There's limited space in this area, whereas underneath here in the subarachnoid space, there's a little bit more space for the blood to kind of pool without compressing the cortex. So usually on an exam, not necessarily in real life, intracerebral hemorrhages are more likely to present with focal neurologic deficits because they're compressing the cortex in this very confined space. And like we talked about earlier, typically choose medical management over surgical unless the two exceptions that we talked about earlier, herniation or refractory to medical management. So these are the four types of bleeds. The most high yield ones, their pathophysiology, and then their risk factors as well. So keep these all in mind and use the anatomy and what you know about where the bleed is located to help you distinguish these. So while we're on the topic, let's do some imaging for these now. So this first one on the left, the arrow is pointing to it and giving it away. So we see what looks like a crescent-shaped lesion here. It sits right here against the wall. It's hyperdense. So this would be an acute subdural hematoma. So this next one, we see, what did I say? Drawing, looks like somebody drew the circle of Willis. So as a baryaneurysm here ruptures, for example, it fills these cisterns with blood. And so it looks like a hyperdense circle of Willis. We know that's a subarachnoid hemorrhage. So this one, we can see here another hyperdense lesion. It looks like there's a convex and then a convex. It's biconvex. It's limited by sutures. This is an epidural. This one isn't well, it's poorly undefined. It's kind of located in the, looks like the parietal lobe here. This is clearly, and it's hyperdense as well. This can tell you that this is an intracerebral hemorrhage. So these are classic images that they may give you and may use this as the way to determine which hemorrhage is which. So keep these in mind as well. Let's move on to a similar related topic. So brain herniations. There are a handful of high yield herniation syndromes that they like us to know. So try and name which ones come to mind. Okay. So I split them up again by color here and put in a picture of the anatomy here on the right to help us think through these. So we'll split this into the etiology, what's causing it, and then any high yield information you may need to know. So the first we have tonsillar down here at the bottom. So what you're doing is you're herniating the cerebellar tonsils down through the foramen magnum. So you can imagine what's happening here, right? The tonsils are here, they're extending into this confined space. You compress the brainstem, and we know the brainstem composes a lot of our vital functions. And so this leads to coma, posturing, and it can lead to death as well. So then you have subfalcine. So this is the cingulate gyrus being herniated across underneath the falx cerebri here. So the high yield for this syndrome is that what runs here, if you think you can't really see it, if you picture an artery right in this spot going through the image here, the ACA runs through this area. So as the cingulate gyrus herniates across, it hits the ACA. So what do we get with the anterior cerebral artery? We get contralateral lower extremity weakness. So on this, if this was the right side of the ACA, you'd get left-sided lower extremity, left-sided leg weakness. Then we have what's called a central herniation or transtentorial. So this is basically where the central portion here of the subcortex is herniating into the midbrain. So this can often cause vascular damage to the basilar artery, which runs kind of right here through the middle of the brainstem, and what's called Dore hemorrhages or Dore. These are little punctate pinpoint hemorrhages that can occur in this area and can lead to what's called locked-in syndrome as well, or it can also just lead to coma. Locked-in syndrome would be a high yield syndrome where you basically have visual paralysis and your arms and legs are stuck as well. And then last we have uncal herniation here, which is similar to central, except it's a less central version of the transtentorial. So here, if you notice, it's not centrally compressing the brainstem, it's compressing unilaterally usually. So the uncus, this medial temporal lobe, herniates under the tentorium cerebelli, which is this right here, and compresses the ipsilateral midbrain. So there's a few high yield findings. This is probably the highest yield of these herniation syndromes. So we know what's in the medial or the midbrain on this side here. So we have cranial nerve 3 is in the midbrain. We know the PCA supplies this portion of the midbrain as well. So you can get cranial nerve 3 palsy. You can get PCA palsy, which causes a contralateral homonymous hemianopsia. And then you also can have sometimes where you have to visually think about it. When this compresses and shifts this way, sometimes you can actually have a contralateral. It's kind of a tricky situation where basically it's called the compression of Kernahan's notch. This portion of the midbrain gets compressed against this angle from this side moving over. And so it's tricky because if you compress this side, you actually get, but the lesion is on this side, you actually get what looks like ipsilateral weakness. And so it's tricky. It's not the most common presentation, but they do like to test the Kernahan's notch and being this ipsilateral weakness. And you're like, wait, but if they compressed ipsilaterally, how are they getting weakness on this side? It's because it shifted the midbrain over to be compressed on the contralateral side, which makes the weakness ipsilateral again. So these are the highest yield herniation syndromes. Uncle probably being the most high yield because there's multiple syndromes you can test with it. Okay, we'll briefly touch on trinucleotide repeat disorders. I think this one's high yield for all of the step exams as well as shelf exams. There's 4, I think, of the highest yield ones that like to be tested. There's more than just 4, but the ones that they like to test us on because they're well defined. Okay, keep those in mind as we go forward. We'll first talk about some key features here. So the first thing is these are 3 key nucleotides. That's where the name trinucleotide comes from, which that's why it's important to know which nucleotides repeat in each syndrome. 2, in these situations, look for family history of similar symptoms. And then the third thing is look for genetic anticipation. So every subsequent generation, as they develop the next, depending on how it's transmitted, these repeats tend to grow in length through successive generations. You get one repeat, and then it turns from 30 repeats to 60 repeats to 90, and so on and so forth. So you can imagine that genetic anticipation is when these symptoms of this exact same disorder either worsen or they happen earlier with successive generations. That is classic for trinucleotide repeats. So let's advance to the repeats themselves. So we have Huntington's disease, we have Friedreich's ataxia, we have myotonic dystrophy, and then we have Fragile X syndrome. So we won't go through everything in these disorders, but we'll go through the high yield and then the basic ways you want to be able to differentiate. So the repeat I have listed there, those are sort of memorization. You can come up with different tricks to keep those in mind. So Huntington's is CAG, Friedreich's ataxia is GAA. Some people use the mnemonic GAIT, GAAIT, because you have abnormal gait with Friedreich's ataxia. And then myotonic dystrophy is CTG, and Fragile X syndrome is CGG. So Huntington's is autosomal dominant. So look for family history, specifically in Huntington's. Friedreich's ataxia is autosomal recessive, so you may not see family history. Myotonic dystrophy is also autosomal dominant, so look for family history. And then Fragile X is X-linked dominant, so look for males oftentimes. So findings in Huntington's disease, remember you get psychotic symptoms and you get choreiform movements. Friedreich's ataxia, just like the name says, you get ataxia. You also get scoliosis and you get pes cavus, which is high arches. And so look for those three findings. Myotonic dystrophy, classically, you get cataracts, you get male pattern baldness, and you get myotonia. So what is myotonia? Myotonia is where the muscles have difficulty relaxing after contraction. So if you shake somebody's hand with myotonic dystrophy and you try to let go, their hand isn't able to let go immediately. That's classic myotonia. And then Fragile X syndrome is everything is elongated and enlarged. So elongated face, enlarged ears, enlarged testes. Additional features here. So the Huntington's disease goes after the caudate nucleus. So you can refer back to the picture earlier, the CT imaging. I didn't go through the caudate nucleus, but it's specifically right next to the lateral ventricles. Keep that in mind. That's where it will be atrophy in Huntington's disease. Friedreich's ataxia often has hypertrophic cardiomyopathy. Important thing to note here, that's the most common cause of death in Friedreich's ataxia. In myotonic dystrophy, you have testicular atrophy. So contrast with Fragile X, where you get enlarged testes, you actually have testicular atrophy. And then Fragile X is a connective tissue disorder at heart, so you get mitral valve prolapse, just like many of the other connective tissue diseases. Those are the highest yield things with these trinucleotide repeats, which can always come up on these exams. So keep in mind the differences and just understand the basic concepts of the diseases. And usually, if you know the classic presentations, you can work your way through these questions. Okay, moving on to another differential here. So now we have vertigo. So there's some high yield topics here to cover in the differential of vertigo. So I'll give you a second. Okay, so let's go through the high yields here. So the first one we have is BPPV, or benign positional paroxysmal vertigo. So the most important thing to keep in mind is the timing. So a patient says, oh, these episodes last several seconds and then they just kind of stop. That's classic BPPV. So it's precipitated by head movement. The pathophysiology is that the semicircular canals have cannulates or crystals in the canals, and they get dislodged and moved. And so as you move your head, it precipitates the cannulates moving, which worsens and causes the vertigo, but it resolves spontaneously. The Dix-Hallpike maneuver, which you can just Google a picture of what that looks like, is what the diagnostic test of choice is for this. And don't get that confused. The Epley maneuver is the treatment. So the first part of the Epley maneuver is the same thing as the Dix-Hallpike, but then at the second part, you turn them to the opposite side, and what you're trying to do is reposition the canalicula or the cannulates in the semicircular canals. So those are the highest yields for BPPV. So how do we tell that from Meniere's? Well, one, Meniere's, the episodes last longer. So that's why I bolded 20 minutes to hours. So they'll last longer. What is Meniere's caused by? So this is what's the high yield is endolymphatic hydrops. So basically excess fluid in the cochlea. So vertigo, just like BPPV, but you also get hearing loss. as your canals are full of extra fluid, which makes it difficult for the hair cells to move like normal. And then tinnitus, and you might see oral fullness as the classic triad or quartet. The treatment is to get rid of said fluid. So you restrict salt in their diet and you treat with thiazide diuretics. You may even see loop diuretics on an exam. So those are the differences between that and BPPV. And then we have vestibular neuritis, which is a subtype of that is labyrinthitis. So this is a single episode. That's how you tell between the first two and vestibular neuritis. And it can last days. And so this is a classic post-viral syndrome, all the things that can occur right after a viral illness. Vestibular neuritis is one of those. And then you may see abnormal head thrust. That's just telling you that the disorder is a peripheral issue, not a central issue. And so you treat this supportively. Most of the post-viral syndromes, like, for example, minimal change disease, actually, that's probably an exception, but many of the other post-viral syndromes, like PSGN, for example, it's not post-viral, but it's post-infectious, autoimmune, kind of resolve themselves. So supportive treatment. Then we have acoustic neuroma, which this one, it can be tricky to distinguish specifically from Meniere's disease. So this one, I would say dizziness is more common than vertigo, as the CNS can compensate for your tumor. So if a tumor grows in a period of 6 months, usually the CNS can accommodate and reduce the vertigo occurring, but dizziness can occur. But if vertigo does occur, don't just pick it if you see vertigo. Look for symptoms of compression. Remember, the acoustic neuroma is happening at the brainstem at the pons. So keep in mind the other cranial nerves that are at the pons besides cranial nerve 8. What's close by? So we have 6, 7, and 5 that are the closest. So look for abducens palsy, facial nerve palsy, or sensory loss with trigeminal nerve palsy as extra hints that it's acoustic neuroma. I wouldn't just pick this with just vertigo. And then you treat this with surgery or radiation, or you could potentially do MRI surveillance. Rarely tested, but important to know. The treatment is different from this in Meniere's. And then the last one here I want to touch on is migraine. So migraine can present in a million different ways, with vertigo being one of those. But don't get confused, because just like a migraine, it should look like a migraine on an exam. In real life, that's not true. But usually look for a history of migraines, and then look for this history where when they're not having headaches, or they're not having their typical migraine symptoms, they're not having vertigo. So if vertigo is occurring outside of this headache, it's probably a distractor. But if it's occurring with this headache or with photophobia, phonophobia, a unilateral headache, so on and so forth with an aura, the vertigo can be the aura. So you treat this like you do a migraine abortives, or an antiemetic. An antiemetic would be good in this situation because it would treat both the vertigo and the nausea. So these are the high yield differentials. Keep in mind the timing. Remember the key features that tell you how you differentiate the two. And then the last thing, keep in mind the treatment. If they make the diagnosis easy, they may give you a treatment, which can trick you up. So that's all I wanted to touch on for vertigo. So let's move on to the next one. So next one is non-traumatic spinal cord lesions. I say non-traumatic because in the surgery shelf review, we cover some traumatic cord injuries. Let's talk about some non-traumatic cord injuries this time. So I'll give you a second. Okay. So keep in mind, just like the traumatic causes of spinal cord lesions, keep in mind the tracks, and then these will make perfect sense to you. So the important ones, there's more than these, but the important ones you want to keep in mind are the lateral cortical spinal tract here, the dorsal columns here, and the spinal thalamic tract. And then the last one here, it's not in the picture, or it's not described in the picture, but it's here, is the ventral or anterior horns. So before we do the disorders, let's talk about what would happen. So the lateral cortical spinal tract is the motor tract coming down from the cerebral cortex, and it's the upper motor neuron portion. So if you get a lesion of the lateral cortical spinal tract, you get ipsilateral upper motor neuron symptoms. Versus then once you get to the ventral horn here, this is the lower motor neuron. So you get weakness, but it would be a lower motor neuron weakness, which lower motor neuron weakness would be fasciculations, muscle atrophy, whereas an upper motor neuron lesion would be hyperreflexia, things like that. So it just looks the same in terms of weakness, but the presentation is slightly different. The dorsal columns connect to the medial lemniscus, and remember, this is proprioception, vibration, and regular sensation. That's what this is back here. Contrast that with the spinal thalamic tract here, which this is pain and temperature. So remember, those are two separate tracts, but these are sensory, so they come from the periphery and go upward. So it's going the opposite direction as a motor tract. Now that we have those in mind, let's go through these disorders. So ALS, amyotrophic lateral sclerosis, caused by a progressive neurologic disorder. And what you have is damage to, so it's here in red, you have damage to bilaterally the lateral corticospinal tracts, and then you also have damage to the ventral horns. So you don't need to memorize this. Just keep in mind, once you know the tract, you know the disorder. So you've damaged the lateral corticospinal tract, you get upper motor neuron symptoms. You damage the ventral horns, you get lower motor neuron symptoms. So this is virtually on exams, the only disorder, and this is almost always what they go after, is you see upper and lower motor neuron symptoms in the same disorder. Usually you get one or the other, but not both. This is an exception. Next, we have tabes dorsalis. So this is caused by syphilis or treponema pallidum, a spirochete. And so the lesion specifically occurs in the dorsal column or the posterior column medial lemniscus tract. And so we know with this tract, what you'll have is you'll reduce your vibratory sensation, you'll have difficulty with proprioception, and so this will lead to ataxia because if you can't sense what's going on around you, your feet don't have any proprioception and they can't sense where they're walking. You can get a Romberg sign and a sensory ataxia, which is ataxia due to sensory problems. And then we have subacute combined degeneration, which is here. This is caused by vitamin B12 deficiency. So this affects the lateral corticospinal tracts, much like ALS, but instead of the ventral horns, it affects the posterior columns. So this looks like a combination of the last two. So you get the sensory ataxia and weakness, or sensory ataxia and vibration and proprioception loss, but you also get the upper motor neuron weakness of an upper motor neuron disorder. Another hint as well is you get a spinocerebellar tract lesion. So even another precipitator for why you may have ataxia. That's not depicted in this picture, but the spinocerebellar tracts are right around this area. So keep in mind, this is upper motor neuron lesions, a sensory ataxia, and then you may even see some cerebellar symptoms from the spinocerebellar tract being damaged. And then the last one we have here is poliomyelitis, which is caused by poliovirus. So this exclusively targets the lower motor neurons, which is the ventral horn and the spinal cord. So while it is bilateral, a hint oftentimes is that it's often asymmetric. So you may see a young kid who wasn't vaccinated from a region that has poliovirus in the area, and you may see that there's lower motor neuron weakness, but classically the weakness will be different between the two legs. So you may see more weakness in one side than the other, but it should be only the ventral horn in this situation. So remember, keep the tracks in mind to differentiate these four disorders from each other, and you'll keep these clear in your head on exam day. So this should be it for the differential section. So we'll go through a few rapid review slides, and then we'll be done. So the first one here, young person after vigorous exercise and a neck injury develops focal neurologic deficits. This is carotid artery dissection. So as the carotid artery comes up into the cerebral cortex, remember that the cortex isn't just perfused by the circle of Willis, the carotids supply the circle of Willis. So specifically, if someone injures their neck, has a whiplash injury, if they fall with their toothbrush in their mouth, if they have carotid vascular disease, so on and so forth, you can get dissection, which can cause focal neurologic deficits. Unrestrained passenger in an MVC presents with comatose with diffuse punctate hyperdensities on CT imaging of the head. So this is diffuse axonal injury. So basically, if you just picture the axons in the skull like they're in a bowl, and you shear the axons from the nerve endings, you basically are seeing these little punctate hemorrhages that are occurring at the junction that were ruptured. And so this is usually a severe presentation. So if you see this on CT head imaging, it often coincides with a very severe presentation. Okay, the next one. A young person with a recent ankle injury in crutches now develops wrist drop. So this is classic radial nerve palsy. Remember, the radial nerve runs in the spiral groove of the humerus, and that oftentimes is vulnerable just under the armpit. And so crutches go with high pressure and stay chronically in the armpit. And so this can compress the radial nerve. The radial nerve is responsible for wrist extension. So when you paralyze the radial nerve, you get wrist drop. So this can happen in a person in crutches. It can happen in an alcoholic. It can happen in someone who passes out basically and lays their arm across a chair all night and compresses the underside of their humerus, so on and so forth. You can think of various ways to cause radial nerve palsy. Next, we have new onset, unilateral, blurry vision, and it's described as washed out. So the colors and things appear washed out. So this is optic neuritis, and not necessarily in real life, but on exams, always think of multiple sclerosis when you see optic neuritis. So this is classic. So it's blurry vision, it may be painful, and it's washed out. So bilateral ptosis, constipation, and respiratory difficulty after food exposure. Questionable food history. Maybe all other people nearby have experienced similar symptoms. So this is botulism. So botulism, remember, attacks acetylcholine, prevents acetylcholine release, and acetylcholine is responsible for most contraction at the neuromuscular junction. So the ptosis is telling you that it's progressing from top to bottom. So it starts at the head and progresses downwards, sort of like myasthenia. Constipation tells you that the anti-muscarinic symptoms, right? The parasympathetic symptom helps you move your bowels. Constipation occurs when you block that symptom or that system. And then respiratory difficulty as well, because you need acetylcholine to move the diaphragm. Okay, we'll do some more. Middle-aged adult with headaches, visual deficits, and a mass crossing the corpus callosum on imaging. This is a classic brain tumor. This is like a GBM or a glioblastoma multiforme. This is also known as a grade 4 astrocytoma. Poor prognosis because of how invasive and how aggressive of a tumor it is. So always keep this one in mind. You may see some hemorrhage and you may see necrosis as well in this tumor. Next one, we have a 40-pack year history of smoking, hemoptysis, and then unilateral ptosis and meiosis. So this is two things in one. So the smoking history and hemoptysis makes you think of lung cancer, and the unilateral ptosis and meiosis makes you think of Horner syndrome. So remember, lung cancer is a common cause of Horner syndrome. Keep in mind that as the superior sulcus in a Pancoast tumor can compress the superior cervical ganglion, you can lead to Horner syndrome, which is paralysis of the sympathetic nerves that travel upwards to the eye. Young child with morning headache, nausea, vomiting, and a mass in the cerebral cortex. This is an astrocytoma. It's the most common cortical tumor in children. Keep that in mind. Sudden onset, severe unilateral periorbital headache, tearing, and conjunctival injection. So in a lot of ways, this may oftentimes look like Horner syndrome, but this is a cluster headache. So the pathophysiology of cluster headaches is likely involves sympathetics, much in the way that Horner syndrome does. So keep in mind that these syndromes can overlap, but also keep in mind that the demographics are going to vary quite a bit. So if you're confused and they put both of these, Horner syndrome, look for a history of a risk factor. So a lung cancer patient presenting with these symptoms, I would think Horner syndrome. A young patient with a classic headache history, think of cluster headaches. But be a little suspicious if there's new onset cluster headaches in somebody who's 50s, 60s. They may be trying to tell you that something else is going on with the sympathetics to the eye. Patient with recent surgery, immobilized in a hospital bed, develops unilateral foot drop. So this is a common perineal nerve injury. So remember, the common perineal or fibular nerve runs laterally to the fibula. So in patients who recently had surgery or immobilized, Oftentimes they rest the lateral portion of their lower extremity on the railings of the bed. And this can compress the perineal nerve as it wraps around the fibular neck. So keep that in mind. Also, in a patient who has trauma to the lateral aspect of their leg, anything that can compress in that area, a cast, sometimes a long bone fracture, and a cast can compress as a hard material digs into the fibular nerve there. So this is similar to radial nerve palsy in that the nerve is exposed at a specific groove underneath a bone, but it's sort of a correlate in the lower extremity. So it's foot drop instead of wrist drop. Because the common peroneal nerve, you have the deep peroneal nerve, which is responsible for dorsiflexion, and then you have the superficial peroneal nerve, which is responsible for eversion. So when both of those are damaged, you have foot drop, and you may also lose sensory on the superior portion of the foot as well, which that portion is coming from the superficial peroneal nerve. Do some last few more rapid reviews here. Elderly patient presents with memory loss over weeks to months, appears distressed, and loss of interest in hobbies. So this is pseudo-dementia, also known as major depressive disorder. Remember, pseudo-dementia or major depressive disorder is a common cause in the elderly, and they often want you to distinguish this from other forms of dementia. So what are the hints here? Weeks to months, the rapid onset tells you it's probably depression. They appear distressed or they are worried about it. That tells you more that it's depression related rather than dementia, where they'll try to write off their symptoms. And then loss of interest is another hint, because anhedonia or loss of interest is a very common and required symptom for the DSM diagnosis of major depressive disorder. Infant with subdural hematoma, which we talked about, retinal hemorrhages, and corner fractures in the metaphysis. So I bolded the metaphyseal corner fracture because that's high yield for non-accidental trauma. So keep in mind, people are starting to catch on to subdurals and retinal hemorrhages. As you shake a baby, the neck and muscles and musculature of the neck aren't strong enough to hold the head upright. And so you have hemorrhages both in the subdural and the retina. But keep in mind that the metaphyseal corner fractures oftentimes happen from grabbing and twisting of extremities as well. So that's another high yield type of fracture. A patient with Parkinsonian symptoms, orthostatic hypotension, and ataxia. So it looks like a hint here is that it looks like Parkinson, but there's plus other symptoms. So this is a Parkinson plus syndrome. And this one is multiple system atrophy, also known as Scheib-Drager syndrome. So keep in mind that for this one, orthostatic hypotension is the high yield symptom here, but you can also have ataxia. So keep in mind Parkinson's symptoms, but significant orthostatic hypotension. They're trying to hint that there's something else in addition to Parkinsonian symptoms. So these syndromes occur when you have the alpha-synuclein deposits in other places besides just the substantia nigra. And then transient unilateral painless loss in an elderly patient, painless vision loss. So this is what's known as amaurosis fugax, which again, it's transient. So it occurs and then it resolves. And so the most common cause of this, remember, is ipsilateral microemboli from atherosclerotic plaques in the carotid arteries. So you always, they may do a follow-up test and say, what do you need to do? You need to do a duplex ultrasound of the carotid to look for a plaque, because this can potentially progress to a central retinal artery occlusion in the future. And this looks different than what we saw with optic neuritis. Optic neuritis is painful, it lasts, and instead of it being a unilateral painless vision loss, it's painful and it has the washout of the colors. It's not going to be a complete, like, curtain loss of vision. And then last one here, we have a young patient with myoclonic jerks upon awakening from sleep. This is some high yield buzzwords here. So the myoclonic kind of gives it away. This is juvenile myoclonic epilepsy. So the awakening from sleep is often where they present with these symptoms. So that's the last of the rapid review here, and that's the last of this review of the neurology shelf. So many of these are tested, and oftentimes they're tested in the way that I presented it here. That's why I kind of touched on it this way. So like and subscribe if you found these videos helpful, and we'll be sure to try and cover more shelf reviews in the future.